Good morning, everybody. What today we are going to see is the assessment of the fetal rhythm. This is in continuation with the previous lectures which we had. What we saw initially was the indications of fetal echo, then we went through the basics, how to do a fetal echo. After that, the last session we had seen the Dopplers in fetal echo. So this is a continuation of that, where we are going to try to understand the rhythm in fetal echo. This is going to be a very basic understanding with a little touch on arrhythmias. The rhythm disturbances are seen in 1 to 2% of all pregnancies, and the incidence of associated structural heart disease is seen in up to 15% whenever any arrhythmia is suspected. And hence, it's an indication for doing a detailed structural analysis also, in addition to understanding what's wrong with the rhythm. Now, why are we worried because arrhythmias are there? One is that persistent arrhythmias can cause hydrops, and overall presence of arrhythmias can increase the mortality in a newborn and also cause associated neurological issues. What we are going to see in this next 1 hour is, when do we suspect abnormal rhythm? How do we diagnose and differentiate abnormal rhythm? And then classify into subtypes, try to understand when are we faced with an extrasystole, or is it a brady or a tachyarrhythmia. So the first most important is, when do we suspect an abnormal rhythm? The normal fetal heart rate ranges from 140 to 20 and then goes a little lesser to 130 plus or minus 20 at term. However, there is a big range in the sense that usually anything less than 100 or 110 and more than 160 to 180 per minute is considered abnormal. But still, there are certain situations where we have physiological variability. So we can see a transient rate going up to 70, 80 per minute also, especially when we apply pressure on the abdomen, or the rate going up to 180, which is transient. Transient means it's for 3 to 4 seconds. And sometimes we can have occasional extra beats also. So when do we consider it within normal range? If it is less than 3 to 4 seconds and if the irregular beats are less than 1 in 10 beats. So an abnormal rhythm is defined as sustained tachycardia of more than 180 beats per minute for more than 10 seconds, or sustained bradycardia when it's less than 100 per minute for more than 10 seconds, or frequent irregular beats of more than 1 in 10 beats. This is an important understanding because in practice, we do face with transient heart rates which fall down, or transient rates which are on the higher side, which is not abnormal. Anything more than 10 seconds is abnormal. The range between 160 and 180 is a gray zone, which we will see as slides move further. And extra beats, anything more than 1 in 10 beats is abnormal. So how do we approach whenever we are faced with a situation where any rhythm irregularity is suspected? This is one of the indications where during anomaly scan, something abnormal in the rhythm is suspected, and then we come across in a situation where we have to understand the structure and also understand what to do with the rhythm. The most important first is history. Check for family history of any long QT, a WPW syndrome, or tuberous sclerosis in previous siblings, and ask for any abnormal fetal movements, diminished fetal movements. The way to check for rhythm is the atrial and the ventricular rate assessment, and then the relationship between the atrial and the ventricular activity. This can be done with M mode and Dopplers. There are newer techniques like fetal magnetocardiography and electrocardiography which can detect P and T waves, which is evolving. And there is something called myocardial deformation imaging, which is also evolving, not available in our country. So the most important would be the M mode and the Doppler, and we try to understand where is the atrial activity, where is the ventricular activity, and what about the relationship between the atrial and the ventricular activity. On 2D, we can also have a subjective understanding of qualitative assessment of rhythm. And we can also perceive something called flutter. Flutter means the heart is beating extremely fast, especially the atrial movement, which we can see on 2D. On M mode, we take a M mode cut of the atrial and the ventricular wall. However, we have to understand that the position of the heart sometimes can give limitations in getting an M mode cut. Also, in presence of hydrops or prehydropic state, presence of more fluid, it can be a limitation to get an ideal M mode cut. The second thing is the VA interval is difficult to measure in an M mode. However, on Doppler techniques, it's more easier to measure. Dopplers, we use basically two types of Dopplers. One is the most common used is the LV inflow and outflow, where we get the 4-chamber and then go to 5-chamber and then get the LV inflow outflow, the mitral and the aortic valve Dopplers. The second is the aorta SVC Doppler in a long 3-vessel view where we can get the aorta and SVC together. So this is more useful for understanding of tachyarrhythmias with AV dissociation like nodal and ventricular tachycardias. The LV inflow-outflow is more better in situations where we have atrial rate much higher than the ventricular rate, like atrial flutter. We can also do Dopplers of PFO and hepatic veins to understand the atrial activity. So now this is an M mode cut as we see. This is the atrial activity and this is the ventricular activity. And here we can see the atria, ventricle, the coordination is maintained. This is where we have cut the atria and the ventricle. It could be the left atrium, left ventricle. It could be the right atrium, left ventricle. It is based on how the position is there for the baby. And this is how then you mark the atrial activity and the ventricular activity and see a coordination. So you have nice atrial activity and then the ventricular activity, and then we have AV coordination throughout. Now, this is just a diagrammatic representation of what we saw in the previous slide. However, here the cut is across the aorta and the atrium, the typical aorta LA cut. If we get this, then we can see here, this is the opening of the aortic valve, and this is the aortic movement, and this is the LA, the left atrial wall movement. Now, how do we decide which is atrial and ventricular activity here? Now here A is the atrial activity, which is the onset of the atrial wall motion. So the onset of the atrial wall motion is the A, and the V is marked by the onset of the ventricular wall motion or the opening of the semilunar valve. So this is the A and this is the V. So this is how we can understand the atrioventricular coordination. Or we can have a cut of the LV. Now, if we cut the LV at the level of mitral valve, we can see the opening of the mitral valve on M mode, typically how we see postnatally. So we have these E and A waves. Basically, they are D, E, F and A, C. So here we can see that the A point is going to be the atrial activity and the C point is going to be the ventricular activity, and this is how you can judge your atrial and the ventricular movements. Coming to the Dopplers. So the Dopplers can be, as we saw in the previous class, we Doppler across the aorta, we are going to get a systolic movement, no diastolic flow, and if we Doppler across the mitral valve, we have the typical E and A waves, the E wave velocity being lesser than the A wave. And what if we take both together? So here we'll see how we take. Now here we can see typically the SVC aorta and the pulmonary artery. It's in long axis. It's a big, I have not zoomed it just to understand. This is a sagittal cut of the baby's chest, and what we are seeing is the SVC, the aorta and the pulmonary artery in a sagittal cut, where you have a 3-vessel in long axis 3-vessel view. And here we can see that the aorta and the SVC are so close. So you zoom this area and you put a Doppler a little more closer to the SVC to pick up the venous pulsations. And then we will see what in the next slide, how the Doppler looks. Now here, this is the LA, LV and aorta. So you get the mitral valve. So you get the mitral valve and the aortic valve together, and you put a Doppler at close to the inflow-outflow, and you will get a Doppler tracing of mitral and aortic together. So now here this is the aorta and this is the mitral. So you can see the E and the A wave and the aortic flow together. So this is mitral inflow-outflow. Similarly, you can see here, this is the SVC and the aorta. As we understand, the aortic pulsations are here, and the SVC has the S and the D wave and the A wave. So the S wave coincides with the aortic forward flow. So now in a diagrammatic representation, we'll try to understand. This is how the LV inflow-outflow Doppler looked. So this is the LV outflow and this is the LV inflow with the E and the A waves. And then we have again the aortic. So now how do we decide the PR interval? The PR interval coincides with the A wave. So it's practically the onset of the A wave to the onset of the aortic outflow. That is what coincides with the PR interval. So here you can see this is PQRS and this is the PR interval. This is LV inflow outflow. So practically the A wave, the onset of the A wave to the LV outflow onset is the PR interval. So if you can see here in this is the E and the A and this is the LV outflow. So this is the PR interval. Coming down to the SVC and the aorta Doppler, the SVC Doppler is having the S and the D wave, and then the aortic Doppler has the single systolic flow which coincides with the S wave of the SVC. So here we can see this is the S and the D wave, the D wave velocity lesser than the S wave, and then the aortic flow. The aortic and the SVC S wave coincide, and then you have the D wave. So the cessation of the D wave and the starting of the aortic flow is the PR interval in this. So this is how it coincides with the PR interval. Now PR interval is important for us a little more for bradyarrhythmias than tachyarrhythmias. However, it gives a correlation between the atrial and the ventricular activity. The PR interval is very important for us, especially to predict any development of second or third degree heart block for mothers who are ROLA antibodies positive. Now this understanding was very important for us. At any point in time, the M mode and the Doppler is going to give us how to understand the atrial and the ventricular activity and how to calculate the PR interval. So the LV inflow and outflow Doppler is a little different than the SVC aorta Doppler. How is it different? In LV inflow outflow, we know that the AV valve is closed when there is any atrial event during ventricular contraction. So in situations where we have tachycardia with AV dissociation, then it is going to be difficult and it's not going to be documented. In contrast to the SVC aorta Doppler, where we can record a retrograde A wave in SVC with systolic flow in aorta. So there is a little difference when you have tachyarrhythmias with AV dissociation, as we saw before, short of ventricular or junctional. In that situation, SVC aorta Doppler is superior. And then we have normal values available for different gestational age for the PR interval, or it's the mechanical atrioventricular time interval. And as we see the gestational age proceeds, there's a little difference in the PR interval measured, and also it differs based on the technique. But on an average, it ranges between 80 to 90 to 120 milliseconds. So this chart can be taken as a standard reference chart to understand whether is the PR interval within the normal range or not. So the first abnormal rhythm we will come across, we usually come across, is the extrasystoles. They are common and they account for 85% of all abnormal rhythms in fetal life. The associated congenital heart disease incidence is very, very little. Most of the extrasystoles are benign, and it is not uncommon to have extrasystoles in pregnancy, which are very infrequent. So as we understand, anything more than 1 in 10 beats is considered abnormal. Anything less than that is commonly seen in pregnancies. However, if we decide that it's more than 1 in 10, then what to do? Now, most of these extrasystoles also do not tend to persist in neonatal period. Reassurance of the mother: tell the mother to be aware of fetal movements. We need to monitor them weekly or once in 2 weeks. Why do we need to monitor? Because occasionally these fetuses with frequent atrial ectopy can develop supraventricular tachyarrhythmias, though the chances are very, very little. The mother is advised to avoid caffeine, chocolate, coffee, tea, and close monitoring. That is all what is needed. Most of the mothers will not need anything. Most of the babies postnatally will be completely normal, and in the future they do not have any issues. However, sometimes if they do develop frequent atrial ectopy and develop SVT, then we will have to go on the tachyarrhythmia path. Here we have to understand that on M mode, when we try to see some of the premature atrial contractions are not conducted, and hence you might see them as a drop in the heart rate overall. So any bradycardia also, a thought has to be given whether is it a premature atrial contraction which is not followed by a ventricular contraction, and this is consistently there. So premature atrial contraction actually comes as a differential diagnosis for bradyarrhythmia also. Now here, this is a very important figure. If we see this video, we can keep watching it and we will realize that in between you see a little irregularity. So most of the times, I will play it again, most of the times it is regular. However, in between we see that there is one extra beat. This is a common indication for referral to a pediatric cardiologist. And then what do we do? Now it looks like it is an extra beat, so it's going to be an ectopic beat. How do we differentiate whether it is a premature atrial or a premature ventricular contraction? Now this first slide shows a premature atrial contraction. So we can see this is an LV inflow and outflow Doppler, and this is the EA wave, and this is the LV outflow, EA and LV outflow, EA and the ventricular systole, and then we have a premature beat which is not conducted. So it's not followed by a ventricular activity, and then it continues, the LV inflow continues till we have the next atrial contraction which is then conducted. So what it is seen is as a bradycardia because the premature atrial beat is not conducted. We can have a premature atrial beat which gets conducted. Then it's going to be a little shorter RR interval and a faster ventricular rate. So a premature atrial beat which is not conducted typically is seen in this way on Doppler. There is premature ventricular beat. Now here we can see that this is the EA wave and the ventricular activity, the EA wave and the ventricular activity, again the inflow and the ventricular activity, and then what happens? There is a premature ventricular beat. The premature ventricular beat aborts the mitral A wave. So whatever we have then, the E and the A wave disappears because the premature ventricular beat has come here. So the premature ventricular beat usually immediately comes after a ventricular activity, and in that situation the E wave is seen but the A wave is not seen, the atrial kick is not seen. And this is how a premature ventricular beat Doppler pattern differs from a premature atrial beat. Now coming to the second type of arrhythmias, which is bradyarrhythmias. The bradyarrhythmias are much less common than tachyarrhythmias. They account for only 5% of all arrhythmias. And how do they look on 2D? So this is how subjectively we can see. In this video we can see that just grossly we can understand that the heart rates are very low. The heart is a little bigger. There is some cardiomegaly. And on Doppler, can we see some AV valve regurgitation? So this is tricuspid regurgitation, which is more than mild. And the heart rate is on the lesser side. Now, once we know that the heart rate is on the lesser side, what do we do? So there are situations where we have sinus bradycardia, which can happen with certain maternal medications, or it can happen with fetal asphyxia or acidosis. If it is sinus brady, in the sense that we see a AV coordination and we think that the sinus node is flowing, with AV synchrony, we monitor the heart rate. If the rates are less than 80, then that could be an indication. Otherwise, we follow them up. Just sinus brady, follow them up. Whenever we have sinus node slowing, there is AV synchrony on the Doppler pattern. Now, if we see this M mode, we can see here the atrial activity, but the ventricular activity is much lesser. Do we have atrioventricular coordination? Maybe not, maybe once in 2 beats. So the atrial and ventricular, here atrial and ventricular, and here atrial and no ventricular. So it is basically atrioventricular block. It could be either every second beat or it could be just completely unrelated. So these are either 2:1 or complete heart blocks. Now complete heart blocks can have associated congenital heart diseases in 40% of situations. So the correlation with the congenital structural anomaly is high. However, when there is a combination of AV block with a structural heart disease, the mortality is high. What type of structural heart diseases do we rule out? Corrected transposition, atrioventricular septal defect, and isomerisms, heterotaxies, are commonly there with heart blocks, but there are 50–60% of heart blocks which are just isolated. So they are isolated congenital complete heart blocks. Now, when they are isolated congenital complete heart blocks, how do we expect the prognosis? The atrial rate and the ventricular rate we document, and if the atrial rate is less than 120, then it is an indication for delivering them early, most likely with cesarean. Now, CS is indicated for very few situations. As a pediatric cardiologist, we need to recommend, and the indication is not more just because we have hydrox or there is impending fetal demise, but because monitoring during normal delivery is difficult for a gynecologist, we sometimes opt for a cesarean section. Now, when CHB is isolated, the prognosis is much better, and ventricular rate is important for us. Any rate which is less than 50 or 55 is not a very good marker for not developing hydrox. So when do we use steroids? When it is complete heart block which is established, especially after 20 weeks, the use of dexamethasone is controversial. Controversial because the benefit is very little, because the damage is expected to be irreversible. And the risks associated with steroids in terms of hypertension, in terms of growth retardation, etc. is high. So in general, when it is an established heart block, usually dexamethasone role is controversial, but when it is a second degree heart block, it is said that it could revert the development of complete, and hence steroids should be considered. Normally, dexamethasone is considered in the dose of 4 mg BD or OD till the baby gets delivered. In addition to that, beta stimulation, if the rates are lesser, could help to some extent prolonging the duration of pregnancy. Now, here we will see basically when we have bradycardia, what all are possible. One is we have a regular atrial rate and AV coordination. So this is a situation where we have most of the times either sinus node slowing or sinus bradycardia. The second possibility is it is irregular, and it is because the atrial premature beat is not conducted. And the third possibility is the atrial rate is regular, but the atrial rate is more than the ventricular rate. So we have low ventricular rates, or it is AV block. So there are three types of bradycardias. The first one, we look at the structure of the heart. If it is normal, we make sure that the mother's medication list does not include anything which can cause sinus brady. The mother's thyroid levels are okay, Rolla antibodies are okay, and then if everything is negative, we could consider a long QT, but nothing to be done during pregnancy and evaluating for long QT after birth. Also make sure that these babies do not go for tachy. Sometimes long QT could present as tachy and brady at different times. If the cardiac structure is abnormal, then we define the anatomy, counsel the parent accordingly, and frequently follow them up. The second subset is irregular rate with blocked premature atrial contractions. Now here also, if we have anatomical issues, then we define the anatomy, but if no anatomical issues, as we discussed before, we reassure frequent follow-ups, avoid caffeine, follow for fetal moments, and deliver. The third component is the AV block. Now, if we have complete heart block and if the heart rate is abnormal, the structure of the heart is abnormal, then we understand that these babies may not make it. The mortality is a little higher, frequent follow-ups, and deliver early. If structurally they're normal, the mother is antibody positive. And if there is heart failure, if possible, deliver, or if not possible, consider dexamethasone with increasing heart rate, beta mimetics. And if Rolla antibodies are negative, you still evaluate them for long QT, second degree AV block, give dexamethasone. Now coming to the second component, which is tachyarrhythmias. Tachyarrhythmias are a little more common, as we said. Now we can look at the video and see, just looking at the heart on 2D, we can understand that this is some sort of tachyarrhythmia. Tachyarrhythmias account for 10% of all arrhythmias, and the associated incidence of congenital heart disease is much lesser compared to brady. And how do we define if they are persistent? Because sometimes it happens that when we are doing a fetal echo, we can see a tachyarrhythmia. Tachyarrhythmia means it's lasting for more than 10 seconds, but it is still not continuously seen throughout the study. So when it's there for more than 12 hours, then it is considered persistent. Anything less than that is considered intermittent tachyarrhythmia. And there is a history of tachyarrhythmia because this was something which was recognized much earlier in 1930s. However, that it can cause high drops was understood only in 1970s. The medications which are given to the mother for treatment of tachyarrhythmias have been going on since 1970s. And whenever we have tachyarrhythmias, grossly we try to understand whether it's supraventricular or ventricular, though ventricular are very, very less common. Supraventricular can be sinus tachycardia, or it can be re-entry, or it can be ectopic, or it can be atrial flutter, or it can be junctional. However, SVTs and flutter and ectopic tachycardias tend to be a little more commoner than junctional. Now, SVTs most commonly are without structural heart disease. However, structurally we try to rule out cardiac tumors, Epstein's anomaly, and myocarditis, especially with ventricular. With supraventricular, tumors like rhabdomyomas and Epstein's anomaly are commonly ruled out. Now, if you see this chart, we can understand that most of the rates are more than 210 when they are abnormal. So when a Tachyarrhythmia is suspected, most of the times the rates are more than 210. But sometimes, in situations where we have ectopic atrial tachycardia or a ventricular tachycardia, the rate can be borderline. They can be 160 to 180. Whenever the rates are less than 165, it's normal, but still, when we have tachyarrhythmias, as we discussed before, say we have an atrial ectopic tachycardia, which is blocked, which is not conducted, you could have rates which are lesser, but still the rhythm is not normal. So the next step comes is, we need to differentiate grossly whether is it a flutter, is it an SVT, is it a VTAC. So how do we differentiate this? Based on the PR interval which we discussed before, and you can have a short RP. Here we use the word VA, where accessory pathway is more common. If it's a long RP tachycardia, ectopic atrial arrhythmia is more common, or you can have AV blocks where flutter is more common. So this is how we would differentiate amongst the three common tachyarrhythmias. Sinus tachy sometimes can happen, and as we said before, long QT can present with sinus brady, sinus tachy. So at different points in time, if we are faced with brady tachy, suspect a long QT. However, make sure the mother's drug intake is okay, hormone levels are okay, including thyroid, any myocarditis evidence, any infection, acidosis, hypoxia can cause sinus tachy. Flutter is a little more easier to pick up if we do a M-mode cut, which is very nice, and we see the atrial rate usually more than 300. So any atrial rate which is in the range of 300, 400, and the ventricular rate is also high, but it's not so high. This is classical of atrial flutter with a fixed 2:1, 3:1 AV conduction. The flutter commonly occurs later in gestation. So when you see a tachyarrhythmia later in gestation, think about flutter to be ruled out, and hydrops. Incidence of hydrops is a little more common. Compared to supraventricular tachycardia, most common would be a short RP tachycardia, and it accounts for 80% of all fetal arrhythmias. And we have an AV conduction. The rates are usually in the range of 200 to 250. It's regular. It could abruptly start and stop, which you could do when you're doing a fetal echo. Hydrops can happen in 40% of cases. However, the risk of hydrops depends upon the duration of SVT. Very, very important. So when you're seeing it and it is persistently there, the risk of hydrops is more. In contrast to ectopic atrial tachycardia, which is a long RP tachycardia, the rates are in between. They are usually in that gray zone around 180 to 20. There is a slow warm up and cool down. And here, if the ectopic atrial tachycardia, the rates are 170, 180, then usually these fetus can be followed up because the chances of hydrops are less common. Junctional ectopic and ventricular tachycardias are difficult to pick up in fetal life. They are much less commoner. Whenever you monitor the rates in terms of separately atrial and ventricular rate on M-mode or Doppler, you'll realize that the ventricular rate is more than the atrial rate. Both of them are individually difficult to differentiate. The rate could be again in the borderline zone, and as we saw before, the LV inflow-outflow Doppler is not reliable. The aorta SPC Doppler is more reliable. Now, if this flow chart can help you differentiate the SVT, the ectopic atrial tachycardias have 1:1 conduction, in contrast to the flutter where atrial rate is more than the ventricular rate, and jet where ventricular rate is more than the atrial rate. The rates are usually very high in flutter for the atrial rate, whereas the ventricular rate is higher for SVTs. For ectopic atrial and junctional, usually the rates are less than 200 or around 200. And the SVT and ectopic atrial tachycardias can be differentiated sometimes if you are fortunate to pick up the start and the end, where it's very abrupt for a necessary pathway and it's slow for an ectopic atrial tachycardia. Now, fetal bradytachy, as we saw before, suspect long QT or sometimes inflammatory conditions. You can have antibodies positive in the mother, which could produce a tachy-brady sort of a picture in the baby. And if there is a block, AV or VA, rule out AV re-entrant tachycardia. How do we manage them? The most important is prevent hydrops, or if hydrops is already there, treat hydrops by converting into sinus rhythm. If not, then rate control. The mortality clearly is based on whether you have hydrops or you don't have hydrops. If you do not have hydrops, the picture is much more clearer. If there is hydrops, 50% chances of mortality. Now, what is the goal of anti-arrhythmic treatment? Do we treat all babies with SVT? Maybe not. There is a little controversy in this understanding. On one side, we say that our aim is term delivery for a non-hydropic baby, because a premature delivery of a hydropic baby is usually fatal. So should we start in utero treatment for all SVTs without hydrops? Now, some people believe that treatment is not essential if the SVC is well tolerated, because the maternal medications are going to have side effects. However, the prediction of the natural course is difficult, and hence the wisdom is you start treatment if SVC is persistent, or if you're not starting treatment, please monitor them very closely for early signs of hydrops. Monitoring closely is usually once in 72 hours. The other option is to start empirical treatment. So what to start, we will see in the next slide. Whenever a transplacental treatment is considered, without hydrops, you get response in the first 48 hours. But if there is hydrops, your response could be a little delayed. However, the long-term prognosis is usually good. If the baby does not respond to transplacental treatment and you are ending up in a prehydropic or a hydropic state, then you should consider direct fetal treatment in terms of IM injections or intraumbilical injections. So what do we see for along with structural understanding? The type of arrhythmias. How do we decide for hydropsis? Look for biatrial enlargement, AV valve regurgitation, cardiomegaly, ventricular dysfunction, and Dopplers, flow reversal in the major veins, or any congestive hepatomegaly, etc. Presence of pericardial pleural fluid and ascites. So you look for these parameters and assess the risk-benefit for fetal therapy. If the mother is near term, the best option would be to deliver after ensuring the lung maturity. But if it is significantly preterm, the lungs are not matured, and you have hydrops, then it's better to consider maternal treatment or fetal treatment. Do not forget the mother prior to starting maternal treatment, because whatever medications we are going to give to the mother are going to be significantly on the higher dose. A thorough medical examination with ECG, electrolytes, renal profile, calcium, magnesium, and thyroid for the mother is baseline done. After that, a repeat maternal ECG is done whenever a dose increase is considered or a second line treatment is added to the mother. Now, in general, for SVTs, and if there is no hydrops, then digoxin is considered to be the first line medication. The dose is usually 1 tablet BD for 3 days, and you increase the dose to 2 tablets BD after 3 days if there is no reduction in the rate or change in the rhythm. After increasing the dose of digoxin, we still don't have response. Sotalol is considered as the second line of medication. However, if the baby has hydrops, then we would consider IV digoxin or flecainide. And then, if IV digoxin does not work, the digoxin dose is reduced and amiodarone is added. If flutter is suspected, then sotalol is considered to be the first line medication and not digoxin. So sotalol is started, and then if sotalol doesn't work, digoxin can be added as a second line medication. Now, in general, ectopic atrial tachycardia, also sotalol is considered as the first line medication. Now, in general, digoxin is considered more safer, more experienced, and more successful. Alternative to digoxin, calcium channel blockers or flecainide can be considered. Sotalol is also an acceptable first line. However, sudden intrauterine deaths are reported with sotalol. This is just a brief. We are not going to go into the detail of individual medication. But in general, if the mother is more than 35 weeks, it's better to deliver if there is a risk for CHF. If the mother is less than 35 weeks and if there is no risk for CHF, you usually monitor them closely. If there is a risk for CHF, then based on the type of arrhythmia, the medication is selected. If there is already high drops, then again IV digoxin versus sotalol versus amiodarone. I think we would end our today's session. Any questions?